Thank you for having me. So when PK called me to speak at NASA, I couldn't answer fast enough. Yes, yes, yes. I am totally a aerospace groupie and closet engineer. It sort of started when my father went into aerospace. He was an out-of-work insurance salesman in the mid-'60s who also had an art degree. And he went to McDonnell Douglas and became a draftsman. So the days before AutoCAD, he was a draftsman, and he drew a lot of the wiring of the DC-10. Now, many of you don't know the DC-10. It came out about the same time as the 747, which was a much more popular plane. The DC-10, my sister-in-law, who's a flight attendant, called it the slave ship because you can see it sits up like that. So when you're working on that plane, you had to climb the ladder all day long. So she said it was horrible for the flight attendants. But it was my father's plane, and I loved it. My husband and I, our very first important date was to go see the Helms Project. Anybody know about the Helms Project? Somebody does. Okay, totally cool, right? You have a nuclear power plant that runs 24/7 and pumps out electricity, right? What do you do with the electricity at night? So they got this great idea. You take the water at the top of the lake, right? I just found how to use this laser pointer. The top of the lake, run it through a turbine and out into the bottom of the lake during the day, get the power, and then at night, you do it all over again, right? So this is how our date went. We drive up to the basically mine shaft, and we step out, and they hand me a hard hat, boots, and a tag that I put on my chest, and then they put a tag on the board. And I'm like, is that in case this collapses and you know I'm in here? They're like, absolutely. Okay, safety, right? So we go into this mine shaft, basically a mile under the lake, and there's these big, giant pipes on the side. And I said, what are the pipes for? He says, well, water runs from the lake above us through the stone and into the shaft. So we have to pump the water out. I'm like going, okay, getting a little nervous now. We get down into the big area where they have the turbines. And my husband turns to me and says, now don't worry. There's no problem with air. I said, you know, I hadn't thought about that. He says, we have these giant fans that bring the air in. Right about then, the air stopped. The fan stopped. In any case, we've been married now for 38 years. It was love at first engineering experience. So the opportunity to be here was something that I really jumped on. However, I then read the program. And I called PK and said, no, I don't think this is going to work. I said, first of all, these guys are really smart. I said, and second of all, I'm in like the after lunch spot. So they're either going to go to sleep or whatever. He said, the program's written, you've got to come. So here I am. And he asked me to talk about safety and innovation. So I'm going to say this. I'm going to ask you just to relax and think big for a few minutes. If you want to take a nap or check your email, just don't let me see you because it makes me very nervous, okay? But otherwise, try and enjoy this. Healthcare and aerospace are a lot alike. It's a lot about safety and innovation and other things. And so in addition to being sort of a closet engineer and a scientist, I started my career in medicine in the military, okay? Anybody here in the military was in the military? I think there's a few, right? Thank you for your service. That was this week's Veterans Week. So I was a field medic and then a nurse in the military. And many of you, I'm sure, are familiar with the fact that incredible innovation comes from military medicine, right? So one of my favorites is the Kitchener stitch. Anybody have any idea what the Kitchener stitch is? In World War I, oh, yes. In World War I, men suffered horribly because their socks hurt their toes. They were homemade socks, they were wool socks, and they were in the trenches, and they had terrible problems with their feet. And Colonel Kitchener wanted his men not to suffer, and he invented a stitch that closes the toe of a sock smoothly so it doesn't hurt your feet. So that's my favorite piece of military medicine. But other things that come from military medicine include the tourniquet, as you might think, soft IV bags, right? They had to have something you could put it under the person's body and the IV was still infused. Letterman Army Medical Center, people know that. That's where I was stationed, actually. Letterman invented the ambulance system. So lots of things. And when I was in the military, I won't say how long ago, but it was a really, really long time ago, lots of things occurred while I was there. So we had the first CT scanner. And I remember we were taking care of this young man. He was 15, 16 years old, very sick, high fever, confused. We didn't know what was wrong with him. And there was no way to look at his brain, right, before CT scanners, except for something called a pneumoencephalogram, which is where you squirt air in someone's back, and it goes into their ventricles, and you can look that way. Not a good test, not very useful. And we got a CT scanner while he was there, and we were able to look at his brain. He unfortunately had a brain abscess. But talk about a miracle of medicine, amazing. Also, when I was there, we had the first time I ever saw an ultrasound. It was nothing like the ultrasounds you know now. It was this grainy thing, sort of, but we actually saw an 8-month pregnancy on an ultrasound. You could almost tell it was a baby. So lots and lots of innovation in medicine. Safety pretty much was relegated to don't shoot yourself and don't get shot. Right? That was the extent of it. Here's your M16. Don't shoot yourself. Don't shoot anybody that you're not supposed to shoot. After the Army, I went to medical school and I became a primary care physician and worked there. As in medicine, you think about quality, satisfaction, cost, right? Call it the triple aim. Okay? So safety is sort of included in quality. Now let me just ask this audience participation, right? Has anybody been on a plane flight recently? Good or bad? How was it? Tell me about it.
I don't know, it was smooth, nothing went wrong.
Anybody else? Tell me about a plane flight you went on. Here. Cramped. Plane flight was cramped. Okay. So you guys did exactly what patients do. You confused satisfaction with quality. None of you said, I got into a 550,000-pound piece of metal. It carried 4,500 tons of explosive fuel. It went to 40,000 feet, which is 0.1 atmospheres. You die at 20,000 feet without additional oxygen, and it's freezing, by the way. Somebody was telling me about batteries freezing. It's freezing. Went all the way up in the sky. I landed exactly where I was supposed to land, alive. You didn't jump out of the plane, kiss the ground, and say, thank you, Jesus, right? You just assumed that it was going to be safe.
It wasn't on time.
What can I say? Right? Now, I tell this story all the time to my new employees because I want them to understand the difference between quality and satisfaction. Quality is what we measure, right? It's the fact that it landed where it was supposed to land, right? You gave the right vaccine to the right person, right? Right name, right person, right place. Satisfaction is about what you like, right? So I practiced medicine for 30 years, took care of people. And you learn one thing in long-term care of patients and in motherhood. Everything you do has consequences, right? Proximal consequences and distal consequences, right? If you teach your kid good study habits, they do well in college. I didn't do so well. It took my daughter 6 years to get out of college, but at least she's going. So when you start thinking distal consequences, like if you don't take care of your diabetes, you get sick. If you take care of your diabetes, you prevent harm. And, you know, in medicine, we're really beginning to think about those things, about long-term global ideas about quality, safety, and harm. And in fact, that's the satisfaction. In Sutter Health, we have what are called the 4 key outcomes, right? Safe, personal, affordable, and accessible, right? And when we talk about safety, we really sort of had a conversation like, what does that mean? That means 0 harm, okay? And frankly, right? Prime non nocere. That's what I promised when I graduated from medical school, right? Do no harm. And, you know, you sort of think about that in the beginning like, oh, well, you know, I gave the right vaccine or whatever. But really, do no harm is lots of things. And I'm going to get really negative for a minute, so I'm going to just tell you, I love medicine. So many incredible things have happened since I've been in medicine. I talked to you about the CT scan and others, but if you think back in 1945, President FDR, what did he die of? Anybody know? Pardon? No. He died of uncontrolled hypertension. And we actually have a very exact record of his blood pressure in the 200s, 250s, and then he had a cerebral vascular accident, a hemorrhagic stroke. They watched him be confused and have blurry vision and all the problems that you'd have if you had uncontrolled hypertension. We didn't know what it was, and we didn't know how to fix it, didn't have anything to fix it. So that's just 1945. There was no medication. When I started in medicine, as I said, there was no CT scans, no ultrasounds. When I first left the military and I was working as a nurse while I waited to go to medical school, I worked in dialysis. 1962, chronic dialysis started in the mid-1970s. It became paid for. There was the Social Security Act for dialysis. But, so all those people that died before 1976 are now living. It's amazing. In 1980, Ken Horn, do you know who he was? Anybody know what happened in April 1980? Do you know what happened in 1981? Okay. In April 1980, Ken Horn was reported to the CDC for having Kaposi's sarcoma. In 1981, he was set as the index case for HIV. I started medical school in September 1981. Okay, you're getting close to how old I am. In September 1981, they sat us down on day 2 of school and they said, there's this disease that's happening. That went on and killed, I'm sure, many thousands of your friends, many of my friends. It was particularly devastating to San Francisco, where I was a medical student, and then in LA, while I was a resident in LA. It was a major part of my life as a physician up until 95, 96. But in 2012, what happened? There is now a pre-exposure medication. There is a medication you can take pre-exposure. Now, HIV is still around, it's still a problem, but it's become a chronic disease. Think about that. Think about the amazing thing that happened. We had no idea. When I started, we were like, is it chronic repeated infections? Maybe brings down their immune system. We had no clue. Think about cervical cancer, right? So cervical cancer used to kill thousands of women all the time. When I started, we did pap smears, right? At least we could find it. Then we figured out human papillomavirus was the cause. Then we figured out how to detect human papillomavirus in the pap smear. And now we have a vaccine for human papillomavirus, right? And now our children, most likely, will not have cervical cancer. They won't have throat cancer or rectal cancer, right, if they get vaccinated. Think about that. I mean, it's a miracle. Actually, my favorite miracle occurred when I was in residency at UCLA. So at UCLA, we did a lot of bone marrow transplants, right? And the way a bone marrow transplant works is we give you radiation and chemotherapy, and we kill you, basically. Everything. And then we get some bone marrow from somebody else, inject it in you, and we wait for your cells to come back. And that waiting for the cells to come back was the deadliest time. And about half the patients died. Every morning, we'd go to their door, we'd check their blood counts. Do they have any white cells? Because when you have no white cells, you get infections very easily, you can imagine. And I don't know how many days. We'd cry when we saw the blood counts because they wouldn't come up. And they wouldn't come up and people would die. And then came Neupogen. We called it PFM, pure magic. You can figure out what that is, right? Unbelievable. We had gone from room to room, day after day, literally watching people die. Suddenly we could give them this medicine, their white count comes back up. Magic, absolute magic. So I believe in medicine. I believe in the wonders of what we've done. Fixed heart catheters. So in my time in medicine, first we started doing angioplasties, and then we started doing stents, and now we put in heart valves in very old people through their leg, right? Amazing. It's amazing what we've done. However, those are all innovative, wonderful things, but under the banner of first do no harm, there are some things that are innovative that we need to be a bit ashamed of, right? 1957, thalidomide, right? To calm you down, to stop your nausea. It went out on the market in Germany. Within 1 year, 10,000 babies were born with no arms, no legs, heart malformations, other things. 1957. So 5,000 of them didn't live, but 10,000, right? It's a terrible thing. Vioxx. I won't make you look at this for long. Sorry. Vioxx, that's another one, right? Went on the market. We found out that 18 months later, you can get heart disease and other things. It came off the market. Fortunately, it wasn't a lot of deaths from that. How about Vicodin, right? The opioid epidemic. Let's think about that. So you can point blame in a lot of places, right? You can point blame at the doctors. You can point blame at the patients. You can point blame at the drug manufacturers. At the concept that came to all of us as physicians that pain was the sixth vital sign, right? We all learned that when somebody's in the hospital, they shouldn't have pain, right? That's the sixth vital sign. I'll ask somebody to name all five, but so the other five. So we asked everybody if they had pain. Well, what does that suggest? It suggests that if you have any pain, it's a bad thing. We made physicians do CME credits on pain control. Everybody had to control pain. People were suing doctors for not giving pain medicine to elderly patients. We were all terrified, right? We began giving out pain meds. And we believed the drug manufacturers when they said that you're not going to get addicted. So Vicodin, sort of wonderful stuff, right? Do you know why it has the name Vicodin? Here's another trivia question for you. VI means 6, it's Roman numeral 6, and codeine is codeine. So Vicodin, 1 milligram of Vicodin, is 6 times as strong as a milligram of codeine. Over the counter, easy to give. There have been 702,000 deaths due to drug overdoses since 1999, right? It's gone up from 5 per thousand to 25 per thousand over the last number of years. Related, 65% of those related to prescription medications, right? We're all to blame, right? In America, we use many, 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 many more times the pain medicines that they use in other countries. So as I said, do no harm. There's other things. CT scans in children, right? If you have a CT scan under the age of 2, or actually several CT scans under the age of 2, tenfold risk of increased risk in cancer for children. List goes on. That's risk to people. What about risk to providers, right? We talked about all those catheter-based technologies. One of our very dear, very favorite cardiology doctors just died from a lymphoma, probably from being exposed to radiation. Now, our good friends have invented a robot to do this work to protect the doctor, but we talk about harm. And then what about environmental waste? That's from us. Pretty gross, huh? Right? We produce 8% of all greenhouse gases from medical environmental waste. And it's increasing because in order to do no harm to providers, USP 800, does anybody know what that is? New regulations on medications, right? So medications that you used to just handle, you have to double gown and double glove and throw all that away. So we think we're going to quadruple the amount of waste and trash that we make. So let's see, we've talked about harm to the patient, harm to the provider, harm to the environment. We forgot one other thing. Medical costs, right? Harm to people. So these are national health expenditures, U.S. population. You can see it's going up. I could take almost any graph that goes like this, and that'd be about healthcare costs, right? So 26% of bankruptcies are related to medical costs, right? And that is not just, it's not just bankruptcy, it's not the cost of a single thing. It's whenever we do something that doesn't need to be done, whenever we create, so to speak, medical waste, right? If instead of spending the time and talking to you about exercising, I give you a medication, I ruin the environment through the waste products of the medication, I don't help you, right? Spend money. What if rather than telling you, learn to meditate, go for a walk, instead I give you Xanax, right? It's much easier for me. And patients are satisfied, right? Love that Xanax, right? Patient satisfaction as opposed to quality, right? So why am I talking about this? Why is this important? I mean, it's important for the obvious things that I said. But I think it's really, really important for you because this is a time that is going to be wonderful and scary for all of us, right? In 1947, less than 50 years ago, the transistor was invented, right? 1947 transistor was less than 50 years after that, the World Wide Web, sorry, because you knew my math. And now, look at all the things that are going on. We've changed our entire lives. What we do, how we sit around and don't exercise, right? But it's changed our entire lives. What's going to happen with the human genome, right? And what's going to happen with CRISPR? You guys all know about CRISPR? Wow. Here's one that got everybody's attention, right? Clustered, regularly interspaced, short palindromic repeats. The ability to cut any little bit of genomic material out and put new one in. And you can buy kits and do it from the internet. It's amazing. So, primum non nocere, right? The greatest danger in the world facing health professionals is the pressure to investigate, prescribe, and intervene non-existing or futile clinical disorders and diseases. Seem to suggest we can do as much harm as long as it is scientific. Now, I don't believe that totally, but I do believe that it is going to take every ounce of ethics, every ounce of thought that we have to prevent ourselves from doing real harm. So, one more. Whoops, maybe I'm supposed to put here. Ah, no. There you go. What thoughts do you have for me? Thank you, and thank you so much. It's an honor.
If anybody has questions, watch the mic. We all have a roving mic box. If you have a question.
Sure.
So one of the questions I have is, questions is that most of what we spend our resources and efforts on from medicine is to cure things or fix things that are already wrong rather than preventing them from happening at all. I wonder if you could comment a little bit about the, an ounce of prevention worth a pound of cure.
Absolutely. I am what some people might call a therapeutic nihilist. So I think that a lot of what we do, maybe we shouldn't do, right? What we should do, when people come to my office, one of the questions I ask them, and I'm going to ask, let's see, who am I going to ask this? I'll ask you this question. How many times this week did you eat real food? Did you eat real food? And I define real food as something that didn't come from Costco pre-cooked, that came from the farmer's market or whatever, and you had to do something to it, or ate it raw.
I don't know. I'd have to think about it probably. Yeah.
Right.
Yeah.
Right. So, in my mind, I come home from work and my husband will say, "How'd your day go?" And I'll go, "Ask me any question." They ask me a question. I say, "The answer is diet and exercise." Right? The answer is don't sit behind your computer. Get out, go, exercise, and diet. We know that. And we have to do that. There's not enough money in the world to take care of a generation of people who don't exercise and who eat garbage, basically. So I am very worried. I worry about my kids. I think, now I grew up without a lot of money. You don't join the Army when you're young if you have money. Just put it all out there, and didn't really eat a lot of meat. Didn't eat, fast food or any of that stuff. And, I think it's been really great. So I've remained healthy and well. But I do worry about kids who, have food that's all prepackaged or food that's been treated with chemicals or single-sourced foods as opposed to natural foods. And I don't want to get into sort of my political thoughts about our food chain and other things, but I do think it's really important for us to all think about health. The other thing about waste, it's not just healthcare waste. It's not like there's a box for, I tell people when they talk about like capital costs and routine costs, right? This is my capital pocket, this is my routine pocket, right? So it's not like there's a healthcare pocket and an education pocket, right? There's a certain amount of money that we're going to pay in taxes. And if we use it for healthcare, and then we won't be able to use it for schools or our kids or infrastructure, right? Okay, what do you think about chimeras to grow human organs in animals? Pretty cool, right? That's an ethical, maybe it's an ethical problem, I don't know. We already use pig valves And we use bovine grafts and other things. We've used animals for people all the time. For grafting for people. So not a bad idea. I think that, transplantation is going to be a huge issue, the continuance of transplantation. And if you grow a kidney, then that's going to save a lot of money because you're not on dialysis. So, I think that's not such a bad thing. I'm a sci-fi person. I can't go with the whole clone. You clone the entire person and use them. There's a science fiction book like that. Yeah.
Yeah, I'm wondering if you could say anything about the problem with fatigue in healthcare providers, especially with medical school students. I've heard a lot about that. People, working 18-hour days, having to make judgment decisions, especially if they don't have a lot of experience, and what you're seeing with that, if you see any improvement in that at all.
Well, so I grew up in the sleep is for the weak, right? So I have to state my bias, which is sleep is for the weak, right? I was saying earlier that Apollo 13 is my favorite movie, right? Those guys had been up for a really long time, but they were well trained. They knew what to do. And so that was the whole idea of the residency program before, right? You just do it so many times that you knew what to do. I did 200 resuscitations in my head. Anytime I'd walk through a room, I'd say, okay, she's down, airway, breathing, right? You just practice those things over and over. So the concept of being sleep deprived and being able to do what you need to do is a long-standing one. There has been a lot of change, and residencies don't do that anymore. You get days off. The problem there is, anybody read about, the 1,000 hours, right? Or 10,000 hours. You have to do 10,000 hours to be good at anything. Well, if you do fewer when you're in residency, then you have to do more when you're in practice. And so as the new residents come, the new doctors come in, they do have a steeper learning curve. So, I'm probably, active health monitoring. Okay, so I think this is super cool, right? Several of my friends have actually had their heart rhythms, their abnormalities diagnosed by their Apple Watch. Apple does more cardiograms in 1 second than the Mayo Clinic does in like a year, right? So it's great, active health monitoring. And in fact, as the population ages and gets older, we're going to have active monitoring, AI systems. I welcome all of that. Is there, you talk about fatigue in healthcare. The real fatigue is burnout, information burnout, right? Now that we have medical records that are really sort of antiquated, just in the way their usability, they're not like Apple Watches. And people bring so much information, right? They bring tons of information with them every day, and to try to get through all the information and make a meaningful decision, it's almost too much. A friend of mine is a diabetic and wears a glucose monitor. And he said it was just too much. Like every 2 minutes he knew his glucose. He was pushing up and pushing down and pushing. He said, there has to be some amount that you can do. So I think it's going to be learning for us on how to manage all these and manage the data. But I do think there's going to have to be an AI component, pushed out information to the patient, and then triggers for when they come and see the doctor. But I do also say that I've never healed anybody without touching them. So.
What do you think of the sort of the new self-diagnosis thing that people are doing now? You go online and you look at WebMD and look up your own information, then you go to the doctor like, I have this, and I do that all the time.
So I believe, and our quality statistics show, that healthcare within a system is better, okay? So I think that those are very usable AI supplements. But I think it's really important for people to be within a system. The problem is when you go to CVS Pharmacy or some of these walk-in cares, there's no back door. It reminds me of a movie lot, right? You walk in, you see somebody, there's no back door if something happens to you, right? There's no catching. I get calls all the time. People can find me on the internet, and I have my cell phone on my thing, just call me up. Hi, I just went to, I won't diss anybody, XMD Minute Clinic, and they told me I have cancer, and now what do I do? Right? Because there's nothing attached. So I think it's really important. I'm a primary care physician. I think it's really important to have a personal physician. You may interact with them differently than you did when I was young, but you should have a personal physician that knows you and knows what your concerns and what your issues are, and then interact with the system.
Speaking of being in the system and all that, my experience with the doctor was that the insurance will drive what the doctor can and can't do. And I've always found this to be just completely opposite of the required touch and the required decisions that a doctor should have the autonomy to make.
So I think there's two pieces there. The insurance doesn't tell the doctor what they can and can't do. It tells them what will and won't be paid for.
Which is a financial health situation.
Right, exactly. But I'm just saying that it's not the insurance doesn't say. So you, as I tell people, I say, you bought the insurance. I didn't buy the insurance. This is what it will and won't pay for. This is what I think you need. It's up to the doctor to try and not ask you to do things that you can't afford, but what they will and won't pay for, it's a different story.
How do you see the role of AI in the future, and do you think it'll be replacing doctors in some capacities or altogether in any shape?
Well, we have like a little app that we're trying out, which is very nice. You can ask it 5 or 6 symptoms or 6 or 7 questions, and it comes back to you with, see the doctor, see the nurse practitioner, or you can pick up a prescription sort of thing. And I think those are good. But, some issues are complex. For example, am I way over time? No. Oh, okay, just checking. So, yeah, go ahead.
A long time ago, 15 years ago, help me PK, the aviation aeronautics industry created a big working group to transform airspace, and they ended up calling it NextGen. And it was a big public-private partnership. And it's more or less actually evolved, and it's actually being implemented now, right? And it was successful. 10 years before that, the healthcare industry created something called the Healthcare Open Systems Standards Group, HOST. And it was unsuccessful because it was supposed to create a shared ConOps and architecture for data exchange. Why do you think healthcare was unsuccessful and aviation was?
If I'm
Or
skeptical,
do you want to do that after hours over a drink?
I think that there's probably lots of pieces to that, right? First of all, we didn't have a standard way of putting information in. So it's pretty hard to, go from one to another. Now we have interoperability. Pam helped write the standards for interoperability. And pretty much Epic is now the de facto owner of the medical record, right? They have Mayo and Cleveland Clinic and Geisinger and all of the UCs and PAMF and all of Sutter, all of Kaiser, right? So Epic is the biggest company, I think, in the world that's owned by a family, right? So to me, that's a little scary, but that is what we have. Bingo. That's what we have. And no one can break into the space, as far as we can tell. I'd be surprised, personally, if the government doesn't step in at some point, because they really own all the medical information. We've had it for over 20 years, so we have the biggest instance of it. So.
Thank you.
Thank you.